I'm Dr. Pritom Muztahid. I am a fellow from Bangladesh FITP program. Today, I'll present a One Health outbreak investigation conducted after detection of H5 avian influenza in a child of Kumilla, Bangladesh in 2025. This investigation began with a 13-month-old boy who presented with fever and diarrhea. He was admitted to Kumilla Medical College Hospital. As part of hospital-based influenza surveillance, or HPIS, he was tested for H5 avian influenza and found positive. Hospital-based influenza surveillance actively run in 9 hospitals in Bangladesh. This H5 positive result immediately raised concern for a possible outbreak and for additional human exposure in the community. H5 avian influenza is a notifiable disease under the International Health Regulations 2005 due to its public health importance. It is highly pathogenic in poultry and can disrupt poultry production and food supply. It also possesses a genetic risk to humans. Globally, 993 human cases and 477 deaths have been reported up to 2025. The image shows a typical backyard poultry settings in Bangladesh, where poultry are kept in close proximity to the household. And in these settings, people are frequently exposed to live birds, droppings, and contaminated materials, which increases the risk of zoonotic transmission. Following laboratory detection of hospital-based influenza surveillance notified the Public Health Emergency Operations Center at the Institute of Epidemiology, Disease Control and Research, which is our National Public Health Institute. In response, a multidisciplinary One Health investigation team was formed, involving human health, animal health, and environmental experts. Our investigation had 3 objectives. First, to identify the likely sources of H5 infection. Second, to assess the magnitude of the outbreak in human, animals, and environment. Third, to recommend control measures to interrupt further transmission. The field investigation was conducted from 29th May to 2nd June 2025 in Kumilla district, Bangladesh. After HPIS notification on 20th May, the One Health team was gathered and deployed to investigate the outbreak. So here you can see the map of Bangladesh. We investigated 2 sub-districts in Kumilla district. On the map, red indicates Lalmai and pink indicates Laksham. Lalmai was included because it was the residence of the index case. Laksham was included because it was linked to the source of frozen poultry meat. For the index case, we obtained the exposure history and traced possible poultry sources. For the human investigation, we defined a suspected case as any person with fever and either cough or sore throat within the previous 7 days, plus poultry exposure or contact with the index case in Lalmai subdistrict. For human case finding, the National Public Health Institute deployed physicians and epidemiologists to conduct contact tracing among household and community members. The team also performed exposure mapping around the index household. We also assessed poultry handling and household biosecurity practices. Nasopharyngeal and oropharyngeal swabs were collected from suspected cases and tested by real-time PCR at the Public Health Institute. For the animal investigation, veterinarians and field investigators were deployed to assess poultry mortality in affected households, farms, and nearby commercial poultry farms. We used purposive sampling in affected and high-risk locations with sample selection based on field feasibility and animal availability. Priority was given to sick, dead, or exposed birds. We observed poultry illness and poultry handling practices. Samples were collected from chickens, ducks, frozen poultry meat, and the dog, and these were tested at the International Center for Diarrheal Disease Research, Bangladesh, which is also known as ICTTRB. For the environmental investigation, the team deployed environmental health field investigators to collect poultry waste community environmental specimens, and poultry samples from affected households. This included poultry droppings, bedding materials, and feathers. Environmental samples were collected purposefully from high-risk locations identified through exposure mapping, including households with poultry days and poultry handling areas. The number of samples was determined based on the field feasibility, as no formal sample size calculation was performed. We also assessed poultry handling and slaughter areas and investigated environmental exposure around the index household. These samples were tested at ICTDRB. The index case lived in a metal-roofed house in Lalmai, Kumilla, as seen in the image on the bottom left. The household kept backyard poultry in close proximity to the living area, as shown in the other image. In this setting, poultry are commonly raised within the household compound with frequent human contact, which can increase exposure to birds, droppings, and contaminated materials. The child had fully recovered by the time of our investigation. He lived with his mother, grandmother, and one sibling, and importantly, no other household members were ill at the time of our investigation. During the field investigation, we assessed 36 households with backyard poultry. Among them, 21 households or 58% reported recent poultry deaths. Overall, 352 chickens and 159 ducks were reported dead. We also observed unsafe poultry handling and unsafe carcass disposal practices, including handling sick or dead poultry with bare hands, keeping poultry in close proximity to household members, and improper disposal of dead birds in the surrounding environment likely increase the risk of onward spread and human exposure. For human laboratory findings, no additional H5 infection was detected during the field investigation. However, some respiratory samples were positive for influenza B and SARS-CoV-2. The index case and all 4 suspected cases that tested positive for other respiratory pathogens recovered fully. This suggests that although the index case triggered the response, we did not find evidence of further human H5 transmission during our field investigation. In contrast, the animal findings showed clear evidence of H5 circulation in the area. H5 was detected in both chickens and ducks, as well as in frozen poultry meat. All frozen poultry meat samples were positive. Environmental contamination was also identified at poultry handling areas. Among community environmental samples, 2 out of 6 tested positive for H5. On this map, you can see the investigation area around the index case household. We conducted the field investigation within a 600-meter radius of the household. In response to these findings, the index case was isolated and monitored. Symptomatic contacts were tested. Risk communication activities were conducted through mosque announcements, community meetings, and posters. The messages focused on safer poultry handling, hygiene, and prevention of further spread. This response was coordinated between IEDCR, ICTDRB, and the livestock sector. Overall, this investigation showed that H5 avian influenza was circulating in backyard poultry in Kumilla, with additional detection in frozen poultry meat and environmental samples. The exact source of infection for the child could not be confirmed. However, the most plausible source of zoonotic transmission was ongoing H5 circulation in backyard poultry. Contaminated frozen poultry meat was also possible exposure pathway. It is also possible that backyard poultry were initially exposed through contact with wild birds. These findings highlight the need to strengthen safe poultry handling, carcass disposal, community awareness, and rapid One Health response to suspected H5 events. Thank you for your attention. I'll be happy to take your questions.